Welcome back to another episode of the Braun Performance and Rehab Podcast, powered by ISOFIT and Oro Muscles. Today I'm joined by Dr. Sabrina Strickland and Dr. Andreas Gomoll. These two are absolutely incredible surgeons, and I'm so thankful for their time. I always learn so much every time I talk with these two. Today we're diving into the patellofemoral joint in particular, in addition to cartilage defects within the knee that way. So a lot of discussion about how to manage cartilage defects, medial patellar facet lesions. We also talk about patellar instability, including MPFL and quad femoral ligament, and so much more. There's just so much information packed into this episode, and I know you're going to love it. Be sure to check out everything Dr. Gomoll and Dr. Strickland are doing if you haven't already. Enjoy. Dr. Strickland, Dr. Gomoll, welcome back to the podcast. I'm super excited to work with both of you again, especially having both of you at the same time. I feel like the two of you really don't need much of an introduction. The work that you're doing is absolutely incredible. And I'm really appreciative of your time on the podcast today.
Thanks so much for having us. I think this is a topic that's near and dear to my heart. You know, I often start, depending on who my audience is, when I'm giving a lecture, just explaining why on earth I decided to specialize in patellofemoral surgery. And most people think it's sort of the ugly stepsister of orthopedics, because historically we just didn't have a lot of great answers. We couldn't necessarily explain why certain people were prone to certain disorders. We didn't know why some people developed arthritis and other people didn't. We didn't have great surgeries to treat instability. And over the past, I would say, 12 to 15 years, we have a lot more options. And I think the knowledge that we have about this joint has expanded significantly in the last 10 to 15 years. Would you agree?
It's also, like anything else, you need to see enough to get the pattern recognition down, because there are many reasons for patellar instability. And if you only see them here and there, you may never actually recognize the causes. So it's old saying, it may have seen me, but I didn't see it, meaning people oftentimes just don't realize the underlying pathology. But we've both done this for a long time, and with that comes kind of a better understanding of something that really doesn't have a good flow chart where you can easily plug in X, Y, and Z and the algorithm spits out your treatment. And I think that's why many people don't like patellofemoral, because
it's not like you tore your ACL, you want to get back to cutting sports, you have an ACL reconstruction. It's a little bit more, I don't want to say it's more complicated, it's just not quite a straight line of a path. And I think really started doing research, patellofemoral research, at least in my case, maybe 15 years ago, when we actually met at the International Patellofemoral Study Group, and that was 9 years ago. So it's been a long time that both of us have kind of thought a lot about this type of surgery. And I know you've looked at some of our research, so I'm happy to dive into that.
And it's interesting because I actually first came across you both a number of years ago when I was still in school preparing for, treating my first patient following an MPFL procedure. And I felt very unprepared to treat that patient. So I was doing anything and everything I could to learn more. And I noticed the name Sabrina Strickland kept coming up over and over and over again as I was trying to learn more about this MPFL procedure. But as we're talking, before we even jumped on the recording that way, I feel like in general, a lot of the patellofemoral cases that I see are very just misinformed, I guess I'll say, as far as the diagnosis goes. They get told they have patellofemoral pain syndrome or patellar instability, but it seems like those are kind of the ends of the diagnoses, and very rarely do I see clinicians look beyond that. And I think a majority of the time, a lot of times clinicians look at the MPFL as the single saving grace to anything and everything related to patellar instability, when unfortunately I've seen patients following an MPFL that don't always do the best. And I think sometimes a little bit more is needed. And I'm curious to kind of hear your thoughts on where we're at as far as this whole process of diagnosing pain or symptoms surrounding the patellofemoral joint, and then your thoughts as far as if the MPFL is the single saving grace, or if perhaps we might need a little bit more to it.
I mean, it almost feels a little bit like the old days of lateral release, where it was this linear thinking where you have any problems with the front of your knee, the solution is a lateral release. And then we learned that, unfortunately, it was very far from the truth. I worry a little bit sometimes that MPFL now is taking that spot a little bit. I mean, we've seen patients who had an MPFL reconstruction for knee pain, but they never had instability.
And that's actually, MPFL should never be for pain. Somebody might have instability and pain, and the MPFL is for stability, but for pain, there needs to be another procedure. So what could that other procedure be? It really depends on the pathology. And that's part of the reason that we're trying to get rid of the term patellofemoral pain syndrome. And I tell patients, it's kind of like saying the front of your knee hurts. So if a patient came into my office and I did a whole evaluation, and I got x-rays and an MRI, and I told them the front of your knee hurts, they would be really frustrated because that wouldn't really be helpful. They know the front of their knee hurts.
That's what they came in.
So it's really more in these patients with, especially with pain and instability or just pain, trying to figure out what's causing the pain. Do they have a cartilage defect in their patella? Do they have patella alta and their patella sits too high, and instead of the force all going through the bone where it's supposed to go, it's going inferior through the patellar tendon or the fat pad? You need to find, and sometimes we don't know what the cause of the pain is. And then, yes, mysterious anterior knee pain is probably the right name for that, but that hopefully is a very rare situation where you tell somebody you have no idea what's causing their pain.
You know, and also what patients oftentimes misunderstand, because it is unfortunately not that uncommon, that you do a workup and you don't find a structural reason that we can point to. So there is, I think, a lot of functional pain that leads patients to pain in the front of the knee. And when I say functional pain, that just comes from a surgical perspective, meaning pain that I can't get an MRI scan or an X-ray or CT and point to the source of pain. And that is something where more rehab, and more importantly, the right kind of rehab is really crucial, because there are many things we can't fix with a knife. But if there is something structural, then you better figure out exactly what that is. And there's always, or I should say, there's never just one answer to a whole spectrum of problems. And that's what Sabrina was alluding to. Some people have pain because they have an unstable kneecap that subluxes, and then the subluxation event that hurts them. And that is something you can fix with instability surgery.
MPFL surgery.
MPFL, or maybe a TTO, or whatever you need to stabilize. So you need to tease out, is the pain the result of an instability event? But if somebody says, well, when I get up from a chair, my knee hurts, that's not fixable with an MPFL.
I like the way that you broke down the MPFL being a solution for the instability problem, but not necessarily the pain. And I think that it's certainly a rabbit hole to try and figure out all the different potential causes of anterior knee pain. Obviously, you threw out the fat pad. There's a number of bursa in the area as well. I've seen some individuals present with bony injuries to the patella, whether that's patellar fractures or stress fractures or, severe bone contusions, different things that way as well. So there's certainly a huge differential list that I think every clinician needs to consider when it comes to sorting out the causes of anterior knee pain. And, as you were talking about the MPFL and how it's, maybe not the single saving grace that we continue to think of it as, I couldn't help but think about the ACL as you were chatting, and thinking about how the ACL surgical approach has evolved. And instead of just seeing isolated ACL reconstructions with a quad graft or a hamstring graft or a BTB graft, I'm noticing a number of patients presenting clinically following a tendon graft reconstruction, but also some form of extra articular ligament stabilization as well, almost as a additional reinforcement for that rotational stability at the knee. And I noticed in one of your studies where you kind of broke down the MPFL and the quad tendon femoral ligament as a consideration for a revision case that way. I kind of thought of that, and maybe this is the wrong way to think, but in my head, I kind of thought of that the way I thought of the ACL reconstruction with an IT band tenodesis, in the sense that sometimes one thing is not enough to fix the instability problem that we're trying to solve. And maybe sometimes we just need a little bit of extra reinforcement to solve that issue.
I think that's a good point. And so as far as just MPFL surgery, so let's take the case where it's perfectly indicated, the patient just has instability, their bony alignment's good, they are motivated to do the appropriate rehab and get good limb control. So when I see one of those patients and they redislocate, I'm hoping to find a technical error. So I'm hoping to find that they put the tunnels in the wrong place, or that they had a significant trauma. Just, I say to patients, just like you could dislocate your patella the first time, it doesn't, of course you could do it again if there was significant trauma. But if I need to go back and do it again, one of our, well, I guess it was before your time at HSS, but one of our former fellows, Miho Tanaka, has done a lot of research. She's now at Mass General in Boston, looking at the anatomy of the MPFL. And the MPFL, it's not like it attaches to a pinpoint spot on the patella and a pinpoint spot on the femur. It has a broader attachment site, especially on the patella. And so some of our more senior, I guess, friends, colleagues like John Fulkerson, who really pioneered the tibial tubercle osteotomy, he's gone to just doing an MQTFL, meaning he doesn't attach it to the patella, he just wraps it around the quad. And then I think Jack Farr went to the, who was in Indiana, just retired, he would just sew it into periosteum, because there are some downsides to making holes in the patella. And at least what I found, because I seem to do a lot of revision MPFLs, is it's like Swiss cheese. You only can poke so many holes. The bone quality often isn't great. And we do know from Miho Tanaka's work that having a broader attachment site is potentially more anatomic. And so that's how I sort of started doing them, sort of that combination. And I think so far that's worked really well.
Is that what led you to use the single all suture anchor for the MPFL and quad tendon femoral ligament?
So it's kind of a little of both. So it's a combo where you're getting some attachment to the patella, but you're not relying on it, and you're getting a larger footprint because it's attaching essentially to two areas.
Especially for revision cases, that's really helpful.
When you do the quad tendon femoral ligament reconstruction, since you have to pull a piece of the quad tendon, going back to that ACL analogy I made before, I'd imagine that incision and, probably roughly about a centimeter sized tendon harvest is comparable to what you would expect for harvesting a quad tendon for an ACL reconstruction, except this time you're using the tendon and the tissue itself for a different kind of stability purpose. Instead of stabilizing the knee joint between the femur and the tibia, we're looking at stabilizing the patellofemoral joint. Is that kind of correct there?
Well, yes and no. So usually for revision, I just make an incision in the quad. So I don't harvest it. I just wrap a graft around it.
Okay.
So usually I don't weaken the quad at all, except there are some cases where, for example, a patient has significant arthritis, so I'm doing a patellofemoral replacement, but they continue to have instability. Then I'll take a strip of quad, but unlike an ACL, it's just a strip of the rectus. So it's just a partial thickness, much less trauma to the quad. And that's something that, especially in other countries where it's hard to get donor tissue, that's a really good option because it's not nearly as traumatic as taking a hamstring from that patient. So I think that, and you also, because it's attached to the patella, you don't have to attach it. So that's more for patients where I think both are good options. I tend to just use donor tissue because then I'm not weakening anything, but I do use their native quad, but only a part of it these days, pretty rarely.
Yeah, and I'd imagine only using a small portion compared to a larger portion that way makes quadricep strength come back much quicker after surgery that way. That's one thing that I've noticed from your work in particular. I saw it with my own dad, how quick he got his quad muscle back. Now, obviously, this is a much different procedure that way that I'm referencing, but it's amazing to me how quick your patients in particular have been able to get their quad muscles back after surgery, because I find a lot of times they're very inhibited and shut down. Is there anything in particular outside of minimal tissue disruption that you feel helps your patients get strength back so quickly after surgery, whether that's, monitoring tourniquet time or just overall managing a fusion or anything along those lines? Or
Actually, so both are good points. So one is expedient surgery. That's sort of obvious, but I think it's a fact oftentimes overlooked that if you're good at something, you're faster, you do less tissue trauma, you do small incisions. So that certainly helps. That's true for anything. Somebody who's more experienced will do a better job. We do really focus on early mobilization. So we don't really mobilize our patients, I would say almost ever. We want them to range very quickly, and we're fairly aggressive treating hemarthrosis, so aspiration. I saw a patient today who was a week out from an ACL, and she had 100 cc's of blood in her knee. You can't really get that person to mobilize or get their quad back until that effusion is gone. We really like blood flow restriction, so we try and get patients into blood flow restriction early on. We also like E-stem just to get things started. So having the right kind of rehab, I think, is crucial. This is teamwork more than anything. So you need a motivated patient, a good surgeon, and I would say even a great physical therapist, or it's not really going to work out.
Is there anything that the two of you look for differently when you're considering a revision case for a rehab following a revision MPFL or revision patellar instability case that way? What kind of things do you consider differently or look for differently, if anything, when it comes to the patient's rehab progression back?
I think we just focus on exactly what Andreas said, more than usual. So we drill down exactly where they're going to do their PT. We make sure they've gone and done a little bit of prehab so they're super confident in who they're going to work with, especially if it's a teenager. I tell parents of teenagers that for my adult patients, their relationship with their physical therapist is important, but for teenagers, it's 1,000 times more important because they need to buy into it. And also, most of these kids are used to playing sports every day after school, so they have to have sort of this working relationship with somebody who keeps them sort of engaged, and that way they'll do their home exercises. I think STEM at home can be really helpful. It's another thing patients have to invest in, so it's not that every patient uses STEM, but I think that can help them also stay on track as far as doing a home exercise program. I think cold therapy and the new ice machines are incredible. I would say that's been a huge improvement over the past year, that people don't have to fill it up with ice. I think people are just doing a better job of icing since the newer machines have come out. But it's everything. And I take pictures all the time of patients, and not all the time, let's say once a month in clinic, where I did one knee and somebody else did the other knee. And if you have a 15 centimeter incision versus a 3 or 4 centimeter incision.
Yeah, completely agree. The less tissue you disturb that way through the procedure, obviously, the quicker someone's going to recover that way. And I certainly see that as being something you're both highly effective at. And as you mentioned earlier, you're very effective at kind of getting to that root cause of why someone is actually coming to see you in the first place. And I think that's also very essential. Going back to that patellar instability kind of concept for a second there, before we jumped on the recording, you referenced the patella alta, and obviously if someone's got that classic, quote unquote, high riding kneecap, then they might be a little bit more prone to instability at the patellofemoral joint itself. And going back to what we talked about as well with that concept of trying to fix everything with the MPFL, I'd imagine that if someone's got an issue where instability is related to malpositioning of the patella itself, you're kind of limited in what a MPFL alone could do there. And I'd imagine that's where you start to consider some more of the osteotomy type procedures for patients, or distalization type procedures as well.
Yes, and I think that can lead to better results for patellar instability, but there's also some things we know about patella alta. For example, we know that patients who develop patellofemoral arthritis are much, much more likely to have alta. So we know it's a risk factor for arthritis. Number two, a lot of these patients, you start to see softening or cracking of their inferior patella, and you see on an MRI that it lights up. Instead of being a dark signal on the fat pad, it can be a bright signal. And so that's a cause for a lot of these patients to have pain. So again, when you have a patient with patellofemoral instability and pain and alta, you can sort of blame a lot of the pain in many cases on the alta. So that's why you try to correct both.
Yeah, there were a number of studies recently, let's say over the last 5 years, that, and the authors say that was not their intention, but that have been interpreted as saying that you can use an MPFL reconstruction to address patella instability even in the setting of patella alta or a very elevated TTTG. I'm not fully buying that, but even if that is the case, as Sabrina just said, we know the long-term implications of patella alta leading to arthritis. So I guess it's because we're doing a lot of tibial tubercle osteotomies that we have become very comfortable with the procedure. And it's not that we don't respect it. It is a bony procedure, but the complication rates are very low. To be honest, I feel it is a missed opportunity if I put someone as a teenager through surgery and I limit myself to an MPFL reconstruction. An MPFL reconstruction plus a tibial tubercle osteotomy is not much longer a recovery than an isolated MPFL reconstruction. You take them away from sports for, 6 months anyways. And I can't say that adding a TTO would change that very much. But you do change the natural history, and you take someone who maybe you fix their instability with an isolated MPFL and they're okay for 10 years. But then when they're in their mid-30s, they still have a high risk of developing arthritis, versus you add the TTO at the time of the MPFL reconstruction, and you've completely changed where this knee will go. I feel some physicians would like to avoid a bony procedure if they can. It's felt to be more morbid, higher complication rates, and are maybe jumping on the bandwagon a little bit in terms of, oh, perfect, now I don't have to worry about that. I can just do the MPFL reconstruction. You can treat a certain part of the spectrum, but certainly not all parts of the spectrum.
As you're talking, you referenced obviously the patella alta, and you also referenced the increase in TTTG distance as well, kind of more on that abnormal patellofemoral side of things and potential cause for anterior knee pain. But I'd imagine another piece as well would just be dysplasia of the trochlea, where the patella itself doesn't necessarily glide through the groove within the femur, or doesn't really fit within the groove of the femur in the manner that you might want to. And I'd imagine if that's not addressed as well, you'd start to see more of that cartilage breakdown on the undersurface of the kneecap, which you referenced earlier as well. So if there is a consideration surrounding this, dysplasia of the trochlea that way, does that change the approach from a surgical standpoint from your eyes as it comes to this conversation of treating the patellofemoral joint?
First of all, we see dysplasia a lot more commonly with alta, and it's still, I would say, pretty debatable if you should change the shape of the trochlea. Obviously, or maybe not obviously, but joints form in relation to each other. So if you are, as you're growing, you do not develop as much of a trochlear groove, so you have a flatter front of your trochlea. You also typically have a different shape to your patella because those bones fit together. And so one issue that we've sort of worried about with people doing a lot of trochleoplasties, making a deeper groove, is that the patella no longer fit necessarily in the groove. So if we can bring the patella into the groove, for example, in a patient with dysplasia and alta, or patients who have dysplasia whose patellas are sitting laterally, if we can do an osteotomy to bring the patella to the groove, that's generally our preference. The way I think both of us were sort of taught, or what has historically been taught, is that everybody should be very concerned about osteotomy, especially distalization, because the complication rates are so much higher. And there certainly are studies showing that the complication rate can be considerably higher. We have personally not found that, but we've also, I think, done some modifications to the technique that have been very helpful as far as reducing complication rates. So people have talked about like number of screws, and they've talked about exactly how you cut your shingle and whether you use a cutting jig, but at least I think we've evolved to do it in a way that is pretty reproducible, and the complication rates are pretty low.
The standard anteromedialization TTO that John Fulkerson had popularized, the way you cut it, you never fully lose stability of the shingle, because generally you don't detach it distally, you just kind of crack the bone distally, and you have a proximal buttress. So mechanically, a standard Fulkerson osteotomy is actually fairly stable. Once you distalize, you lose both. So you have to mobilize the shingle, so that distal transition, you have to disrupt that. And then because you move the shingle distally, you don't, at least not with the standard technique, you don't have a proximal buttress. So you're fully relying on these 2 or sometimes 3 screws to give you enough compression to keep the shingle from gliding. And that's not a very mechanically stable construct. And we've done a biomechanics study with our Alto technique where we add a proximal bone block, so we preserve that proximal buttress, and then we change the angle of the screws to aim more distally, and that modification, if you look at the stability of a distalization tibial tubercle osteotomy, is pretty much identical to that of a standard Fulkerson. Shows you that if you think through how you do it technically, you can modify your technique and still make a stable construct, and that translates into a clinical study that we did just looking at the complications of distalization. And as Sabrina had mentioned, in our hands, we haven't really seen an increased risk of non-union or fracture. One should not treat patella alta just over concerns for a distalization TTO. I think alta is enough of a problem that it needs to be addressed. And with the right technique, you can safely. And then to your question about the shape of the trochlea, we had mentioned before, anything has a certain spectrum. Trochleoplasty has become way more popular, and people have started doing trochleoplasties, even though they don't. Unfortunately, trochleoplasty is technically a very challenging procedure. We do see patients who have the most severe, called a de jour D type of dysplasia, where instead of the normal concavity of the trochlear groove, these patients have a convexity that extends from the proximal groove all the way distally into the notch. And you can't balance round on round. You can't balance, unless you're very skilled, but you can't really balance two basketballs on top of each other. So that may be a patient who would benefit from a trochleoplasty. For the most part, though, the dysplasia that we see, and I would say that's probably 95% of dysplastic patients, have much milder forms of dysplasia. So technically they are dysplastic, but they may not have the concavity, but they're not convex, they are flat. And between a tibial tubercle osteotomy and an MPFL reconstruction, those patients can be stabilized generally with very good outcomes. So it's the rare patient that I feel is so severely dysplastic that they really require trochleoplasty.
Yeah, I love how you broke that down. And I love, to your point as well, how you're able to produce extremely stable and consistent results with some small modifications. You referenced the bone block, and you referenced the changing in how you place the screws surgically as well that way. Is there any other unique considerations that you feel have led to your success with the modification of the TTO with distalization? And does that change at all when you consider other things that might be involved with those types of procedures, whether that's, placement of a wedge or lateral lengthening that might occur in conjunction with those procedures as well?
Well, as far as the osteotomy, so we have all different kinds of screws we can use, and everybody sort of has their, different. We personally don't even use the same screws, but I think there's some pretty simple things that make this a more reproducible operation. First of all, the worst complication that you can have after tibial tubercle osteotomy is a tibial fracture. I've only seen a couple, and thank God they weren't on my patients, but it is a stress riser when you cut the tibial tubercle distally, especially as you're getting closer to the tibial shaft. And at least the way we do distalizations is we feather it just to a very thin point. So it just means that the stress riser is a little bit less and the bony overlap is greater. So I think you have a larger healing surface. And then the bone block proximally is an allograft. So it's freeze-dried bone. It's no risk of disease transmission. It's something that just sits on the shelf. It's easy to get. So I think, those minor things really make a huge difference. The other thing that I would say is that people have always worried about distalizations increasing contact pressure. And that's because when they used to do distalizations, they didn't anteriorize it at the same time. So anteriorizing takes pressure off. Distalizing may increase the pressure, but it really depends what the joint's like. So if you have a very high patella, you're preferentially loading the inferior aspect of the patella. If you distalize it, you're increasing the amount of surface contact, and by increasing the amount of surface contact, you're actually decreasing the stress for each little area. So you're reducing stress overall by increasing the amount of contact. So it makes perfect sense when you sort of explain it, but it was just sort of taught that if you bring the patella down, it's increasing the stress. You can't do it if there's any cartilage wear, and that's just not true.
And part of these early kind of confusing results also came from biomechanics study that in hindsight, one would say, well, of course that wasn't the right way to go about the study. So when you order cadaver knees for biomechanics studies, it's not as if you can order a knee that has patella alta or an increased CTTG. You just order a knee. So many of these early biomechanics studies were done in knees that you would clinically never indicate for these procedures. So you would order a cadaver knee and it may have a TTTG of 12. Most of the early biomechanic works, they didn't do CTs or MRI scans for these cadaver knees to determine what the TTG actually was. And then they did a tibial tubercle osteotomy in knees that probably 80% of the cadaver knees at least were totally normally aligned. Then you do, whether it's a medialization or a distalization, so you take a knee that is actually normal and you make it abnormal. And then that showed that you increase pressures over the medial facet or the distal facet. Some studies since have done similar biomechanics studies, but they actually measured what the TTG was. Then they artificially increased the TTG by doing a tibial tubercle osteotomy and moving the tubercle lateral. So you simulate an abnormal joint. Then you do your measurements in the abnormal joint, and then you normalize it. And those studies now have shown that you're actually not increasing the load because you improve the surface area and the congruency of the joint. You actually decrease the load per surface area. So it just shows you you need to read between the lines in many of these older studies and not just take the headline.
I think my first 3D printing study was probably around 8 or 9 years ago, where we basically could take an MRI of a patient that had severe dysplasia. I still remember who that patient was. We 3D printed it, and then we basically screwed it onto a cadaver knee. So we basically took the front of an abnormal knee, we sized it to that cadaver knee, and then we screwed it on. So basically the front of the knee was abnormal. And then that allowed us to do a number of different biomechanics studies looking at contact pressure and then changing variables. So doing an osteotomy, and looking at, you use these little sensors called TEP scans that are the biggest nightmare in the world to use, but they're great because they show you exactly how much pressure each little part of that joint is feeling. And you see a graph is how much pressure and where exactly that pressure is occurring. And so, we haven't solved all these mysteries, but we're certainly getting closer to trying to figure out as far as how we move the tubercle, how we unload it, and then potentially why some parts of the patella are wearing out that we didn't understand, which brings us to the medial facet, which was on my to-do list forever. But
you bring up such an interesting point with that medial facet, in the sense that it's something that I feel like in particular the atraumatic medial patellar facet lesion is something that we know very little about. Yet it's one of those things, I think you used the term earlier, Dr. Gomoll, that sometimes these things see us, but we don't see it per se. And I think that's something that we all need to be a little bit more aware of on the clinical side of things, in the sense that sometimes, going back to where we started, sometimes we're very quick to just call something patellofemoral pain syndrome, and we don't think to look a little bit deeper, a little bit quicker. Someone gets a little bit better after a few weeks of PT, and we just kind of assume that's that. And sometimes I think there's a lot of value in looking into some of the deeper stuff to try and get a little bit more understanding of what could be going on. And I would imagine if you're trying to kind of get into that medial patellar facet lesion, you can probably get a majority of the diagnostic considerations off of just a simple MRI that way. Whether that's asymmetry ratios or various indexes that you can calculate, or the depth of the sulcus itself. I feel like a lot of the different things can be done through technology that's pretty widely available across the country. At this point, it's just a matter of looking deep enough and making sure we catch these things.
Yeah. So with increased recognition, sometimes also comes increased frustration.
More complicated because there's so many measurements.
Yeah.
If you see, I don't know, we both see between 35 and 45 patients a day in clinic, and obviously some of those are post-op, so not everyone is a new patient that we have to measure 100 things. But you're right, we do get a lot of information. I would say for a patient like this, we get a lot of information just from their just talking to them. And then we get a lot of information from an MRI.
So what kind of things in the patient conversation would clue you to think something along the lines of a facet lesion? And then what kind of things from the MRI standpoint, if you had to pick like 2 or 3 of the several numbers that you have to look at that way, where do you kind of hone in on from a clinical practice side of things?
From the MRI scan, and that's what sort of leads to this frustration even with increased recognition. So when I see someone who has on an MRI scan a medial facet lesion, then generally that can be 2, at least to us, obvious thing. 1 that's a little bit more hidden. That's what we recently looked at. But medial facet lesions either are traumatic, so you have a patella dislocation. That's sort of the most common reason for a inframedial patella facet lesion. And sometimes they're small. They happen because you sort of jump the curb, but it's not a very high loading area inside the knee joint. And some of them can be safely just ignored and you fix the stability. If they cross into the median ridge or across the median ridge, those are large enough, and then we would both, I think, fix those. That's comparatively simple. Traumatic medial facet lesion, great. They also happen in conjunction with patella alta, and that's also great because when you fix the patella alta, that area will be relatively less loaded, and then you can make a decision whether you fix it in addition to fixing the patella alta, but at least you do something to improve the biomechanical environment. So you can change the natural history, as we mentioned before. This recent study that Sabrina did is both interesting and a little bit vexing because it looked, and I'll let her speak to that, at different angles. And you mentioned this asymmetry ratio. I'm just not sure that this is something that at least currently we can actually fix. Meaning we can fix the cartilage defect, but that is one part of the anatomy that we can't really fix yet. But hopefully with further research. But
well, I think what we can fix, and so there have been at least 3 studies now looking at patients who had patella cartilage pathology, where one was a big database study where they just looked at MRIs and they measured what you call tubercle height or sagittal TTGG. And I explain this to patients like it's how bumpy their tibial tubercle is. It's how anterior. And so just like we talked about already, that in some patients we want to anteriorize their tibial tubercle to unload it, these patients start out posteriorized. And so the database study basically showed that patients without a history of trauma were more likely to have patellofemoral cartilage pathology who are more posterior. So interesting. And then that was Drew Lansdowne's study. Then Adam Yankee, a friend of ours at Rush, he looked at his patients where, and again, just in their series showed, I think they just looked at their chondroplasty patients, but that patients were more likely to have cartilage pathology with a posterior tubercle. But again, this is just, and then we looked at our patients where no history of instability, but we're looking specifically at our medial facet patients, and those patients had a more posteriorized tibial tubercle. And why that is gives us a little hope, it gives us a little more of a plan of how to treat these patients. It's one thing to treat the cartilage, but secondly, like to put that cartilage in a less hostile environment. And I think that's making us a little bit more likely to anteriorize these patients, just doing a straight anteriorization. And again, the old way we were taught to do anteriorization was called a McKay, where you had to anteriorize it 1.5 to 2 centimeters. So the skin issues were major because there's not a lot of laxity in the skin right over the tibial tubercle, but we probably don't need to anteriorize it anywhere near that much. And so that's where new ways of measuring contact pressures, and because what we're seeing is most of these patients are only 3 to 5 millimeters posterior. So maybe we only have to anteriorize them 6 millimeters or 8 millimeters. We don't know yet, but that's probably what we're working on now. That's most like work in progress. I don't have a complete answer, but I think we're following the trend of our research, and it is changing how we're doing things, I think.
It also influences a little bit what cartilage repair technique we may choose. So if we have someone who has an anatomic or biomechanical environment that either is normal, or we can normalize it through osteotomies. So we can normalize patella height, TTDG, and it's a contained lesion. I would be more likely cell-based therapy, like MACI, for example. But in someone who has a cartilage defect, and it may be that even the tubercle position anterior to posterior is normal, and they just have one of these mystery lesions where we still haven't found a reason why. I would err more on the side of doing an osteochondral procedure, so either an autograft oats, which is a little bit more rare, or an allograft, mainly because that is fully grown mature tissue that is more resilient. And there are some studies that have shown that if you use an osteochondral allograft, it is less sensitive to the biomechanical environment than if you use cell-based therapy. As we started this, there's so many facets to patellofemoral, and I think that's why a lot of physicians back away from that a little bit, because it at times can be overwhelming.
It certainly can. And to your point on the cartilage defect side of things, choosing between the Macy or the Oates procedure that way, I know you've done some different work recently, kind of comparing that single versus multi-plug Oates type procedure for that osteochondral lesion within the knee itself that way. What might lead you to decide between a single or a multi-plug? What is the difference between the single and the multi-plug technique? And what have you found from a outcome standpoint from the research that you've done and from what you see clinically on the day-to-day?
First of all, just to clarify, because I think it can be very confusing, it's certainly confusing for our residents, Oates versus OCA. So at least I use Oates for osteochondral autograft transplantation system, which is a system that Arthrex sort of came up with. But so Oates I use for using your own cartilage, which if we're talking patella, since typically you're taking the plug from the trochlea, it's pretty rare that I would take cartilage from the trochlea and put it in the patella, because now I have a defect in the trochlea. So secondly, the patella cartilage is the thickest cartilage in the body. And so when you're transplanting from another area of the knee, it's thinner cartilage. So it doesn't mean it doesn't work, but I wouldn't say it's our favorite.
It's more tricky. Yeah, because the two surfaces, the defect surface and the donor surface, essentially face each other. And you can make a case that you could harvest from the lateral trochlea and put the plug in a medial defect, or vice versa. But moving cartilage within the same compartment, I feel, is a little challenging. So those tend to be very special circumstances. And I think for the most part, also because we see larger lesions that then would require multiple plugs, and then you make multiple holes. So we tend to use more.
And there was a study years ago at HSS, neither of us did this study, but they looked at Oates for the patella, and they had about a 70% of the plugs were congruent. And when I talk about that study, I will say, if your tiler did your bathroom and only 70% of the tiles lined up, you wouldn't be super happy. But it's really hard to get those plugs exactly. Never mind the donor site morbidity of taking cartilage. So predominantly we're talking about OCA, and then single versus multi-plug in the knee. It really depends on the shape of the lesion. So if you have a circular defect, you're going to put in a cylinder and you're going to do one plug. But a lot of defects on the condyle or on the trochlea aren't circular. And so your options are either do a massive plug, which is hard.
Yeah, it's a challenge in terms of matching the congruency and also just the sheer volume of bone that you transplant. Because osteochondral allografts, it's not the cartilage that elicits an immune response. It's really the subchondral bone and whatever bone marrow we weren't able to wash out. And it's not as violent a reaction as we see in solid organ transplantation, but it still contributes to failure. So we try and minimize the amount of bone we use, and it's really just, given the plugs being 3D, if you use one gigantic plug, there's just more bone than if you use two smaller plugs.
So there was a company that came up with this idea that seemed great. It's not so great in hindsight, where they called it a bio-uni. So they basically created instrumentation to create an oval plug. But just trying to think what the best analogy is, like if you cut like a wedge of cantaloupe, like on the edges, the cantaloupe's pretty thin, but in the middle, it's really thick. And the exact same thing happened because the contour of the knee is like a cantaloupe. So the middle ended up being really thick, and it meant that there was a lot of bone you had to grow into, and the failure rate was pretty high. So I don't think anyone's doing that, I would assume, anymore, because we obviously don't want any failures. And so that's why we got to the multi-plug, which in our hands, the results looked good.
The goal is still, if we can get away with a single plug just because there are fewer moving parts. That's preferred. So if something is perfectly round, then a perfectly round plug is the solution. But as Sabrina had mentioned, most defects are oval. And if it's sort of a lazy oval, then you increase the plug diameter to cover the longest dimension of that oval, and you sacrifice a little bit of healthy cartilage adjacent to sort of the skinny part of the oval. But if it's a truly long and narrow defect, then you can't retreat that with a single plug. And there are studies that have shown that multi-plugs somewhat higher failure rate than single plugs, but nobody uses two plugs just for the fun of it. I think that's more a reflection that we're using multi-plugs in defects that are larger and more complex. And with those, I would expect to have a higher failure rate, and that's what the studies have shown.
Yeah, and that makes a lot of sense intuitively, in the sense that if it's a larger defect, you need more tissue to cover it. And obviously, the more involvement there is, the higher the risk of complications, as you referenced there. And I couldn't help but wonder, as we were talking about kind of the cartilage defects that way, is I've seen a variety of different mechanisms that kind of lead to these different cartilage defects. And some of them present in conjunction with ACL injury, some of them present in conjunction with patellofemoral injury as well that way. So clinically, what kind of things have you seen kind of lead to patients coming to see you with these cartilage defect type injuries that way? Is there anything that people should be considering to prevent them from happening? Can they all be prevented? And, on the mechanism side as well, do you see more present in conjunction with ACL, more in conjunction with patellofemoral? What do these things kind of present with often in your clinical side of things?
So I think one unfortunate thing, this is because cartilage damage and osteoarthritis is sort of a continuum. On the better end of the spectrum, where it's focal, we call that cartilage defects. On the more diffuse side, that we call that osteoarthritis. But it's sort of one leads to the other eventually. And the same way, unfortunately, we haven't figured out how to prevent arthritis. There's no way to really prevent cartilage defects besides the public service message of do the right kind of exercise, control your weight. I would say most cartilage defects are either trauma, and of course we try and avoid that, but you can't only sit on the couch, or there's some genetic influence, whether that is patella alta, that then because of the altered mechanical forces leads to cartilage defects, or there's something about the cartilage quality that's not good. And we see these young patients with multifocal, meaning multi-compartment defects, where we don't find any biomechanical explanation for it. So there isn't really much we can do, unfortunately, to avoid cartilage defects. But more specific to your question about do we see that with ACL injuries and patellofemoral instability, we do, and there are many studies that have looked at the incidence of cartilage defects with patellar dislocation or ACL tear, and the incidence is very, very high. But the problem is the majority of these cartilage defects are minor. With an ACL, I would say it's rare that I look in an ACL injured knee and don't find something that I could call cartilage damage. But it may just be a little bit of a fissure in the anterior lateral femoral condyle where sort of that kissing contusion happens. So you can call something a cartilage defect, but it's not really a meaningful or symptomatic defect. And that's where the tyranny of numbers in terms of statistics comes into play, because a lot of people have said in the past, oh, cartilage defects in the setting of patellofemoral instability or in the setting of an ACL tear, they don't matter. People have taken this as, oh, you can ignore this stuff and you just focus on stability. And I would say there aren't many examples in medicine where there's not a spectrum of disease that gets treated depending on what end of the spectrum you're at. So what I mean with tyranny of numbers, if 70 or 80% of what you call cartilage defect is minor, the expectation can be that those patients will do fine regardless of what you do. But having someone who has a few fissures in his anterolateral femoral condyle that's not even really weight-bearing is very different from someone who, while they tear the ACL, also have a 6 square centimeter delaminated defect in the medial condyle. But I have seen physicians who have said, oh, this is cartilage damage in the setting of an ACL. I was told that doesn't matter. And they were being told that it doesn't matter is because that one or two really large cartilage defects in any statistical analysis get drowned out by the vast number of patients that have little things. So I think the one comment I would make is you have to look at each patient individually, and if they have a large defect, then it doesn't matter if this is in the setting of patella instability or ACL tears, you treat the cartilage defect and not just ignore a real defect because, hey, the other 80 people just have minor things and will do well.
I mean, and the specific reason we did the single versus multi-plug, that just comparison is, there are a lot of, our average age was 37. And so these aren't patients that you want to do arthroplasty on anyway, but there's certainly patients that you see that I think it's easy if they're 22 and they have just an isolated medial condyle defect and maybe you don't know why, you're just going to fix it. But when it gets a little more complicated and maybe a little bit more controversial, and although I don't think we think it's so controversial, is, let's say I see a 40-year-old who's super active and has a trochlear lesion and a medial condyle lesion. I see them all the time where they're told either there's nothing they can do, they have to wait till they're 50 and they can have a knee replacement. Whereas our studies showed that they actually did the same. If we put 2 plugs in that patient versus 1 plug in a 30-year-old, they actually did the same. Now, I don't think they're going to be the same at 10 years because that patient who has multiple lesions probably is on some type of osteoarthritis trajectory that they're going to go south at some point. But it's totally different if you can get to 50 and be active and have a knee that feels pretty good than if, you have to just grin and bear it for those 10 years.
This multi-plug that Sabrina just mentioned is also, it's a little, so what I mentioned before about multi-plugs have higher failure rates, that's if you treat one lesion in one compartment with multiple plugs. That was Dr. Cole's study a while ago. This multi-plug, that's really a multi-compartment.
Yeah. It was both, but it was either large oblong, but at least we had 60 patients, so we had 30 in each group, and the results, at least with a minimum 1-year follow-up, which I admit, like some of these, the 2 failures were actually in single plug patients and they were at 3.5 years. And that's a whole nother, I mean, we can talk about forever about exactly what the outcome is. So if you look at the Canadians, or what's his name? Alan Gross. I mean, nobody fails cartilage transplants because it's really hard to get a knee replacement in Canada and you have to wait years and years to get it. So guess what?
You also can't really have a revision because the graft tissue is so rare.
Failure rates, if I tell you that your next operation is a knee replacement, you'll probably wait longer than if I tell you, oh, I can revise it with another OCA or something else that's smaller. You just have more options. Yeah, no, and it's just like we have more options. So depending on who's doing the study and what they look at as a failure, meaning you have a lot of pain, I mean, I would consider that a failure, or you have a knee replacement, that's definitely a failure. But there's a huge spectrum of what we consider a failure.
Yeah, I completely agree. And ultimately, it's all about not just getting the patient back to where they want to be in the short term, but the long term as well. And you brought that up beautifully in the sense that if we fail to get the patient back to where they are in 3 years' time or 5 years' time, or, even in that 8 to 10 year range, obviously, not everything is going to be successful in the sense that there are freak things that happen, right? Sometimes a procedure gets done on an athlete, they get back on the field, and then a freak thing happens that no one could have prevented. No amount of PT, no, surgical consideration. Freak things do happen, but I think that the more we take the time to look into the considerations that we need to address from a surgical standpoint, the things that we need to do from a rehabilitation standpoint, the more we listen to our patients and the more we kind of keep that long-term goal in mind, the better we're going to do by the person in front of us. And I think that's what it's all about at the end of the day is, again, making sure that our interest is always in mind or in line with the patient in front of us at the end of the day, and understanding that in order to do that, we have to be constantly evolving and learning and having discussions like this one here and kind of rethinking how we've always done things and thinking about what the next evolution could be or what other considerations we need to, address that way from our clinical practice in order to better provide to the patient in front of us. And I think that's something that obviously the two of you do exceptionally well. I think you've both published more studies in the past 3 years alone than I think I've read in my lifetime. I think that you two do incredible work that way. And I think that, anyone who's listening thus far should definitely consider reaching out and keeping up to date with your work that way. Where can people find you online? How can people stay in touch with your research work and keep up to date with your research profiles that way?
Speaking for myself, I mean, we typically post every study that we publish on Instagram, and I try to make a short commentary on it just to try to put it more in layman's terms, depending on who's reading it. I mean, both of us speak at the major orthopedic conferences, although I think we're skipping one right at this moment. But, the Arthroscopy Association, the American Orthopaedic Society for Sports Medicine, Cartilage Repair Society. We just got back, in August from the International Patellofemoral Study Group. We put on a patella meeting at HSS. God, that was probably 6 years ago. We need to do it again. I think we like if somebody's local to New York, especially physical therapists will reach out and say, can I come to clinic? I mean, we have physical therapists come all the time to clinic just for a couple hours, and I think universally they find that super interesting because they hear how we're explaining things to patients, which is kind of how we'd explain it to anybody.
It's also very findable on the internet. So we have websites, and on PubMed, people can find us pretty easily.
Yeah, I've noticed you two don't have TikTok channels yet, though. Is that
No.
in the works or?
Nothing.
No TikTok.
No.
Awesome.
Too busy clinically to go overboard.
Oh man, I was really hoping to see a little Gomoll dance with his next patient that way, but
Yeah.
is
We're
there
working
any?
on the choreographics for the patella dance, but it's
It's
complicated.
gonna be a few years.
It's gonna be a few years.
Oh man, is there anything that we missed as we were chatting today, or anything else that you wanted to bring up in relation to our discussion around cartilage and the patellofemoral joint?
No, I think we've covered a lot.
Yeah, I mean,
And I always encourage people our office email is Strickland Gomoll, sgoffice@hss.edu. That goes directly to our athletic trainers. And so we're always happy, we both do telehealth. So we're always happy, for people to email us or to do virtual consults because, ultimately I want everybody to get to the right answer. And, not everybody lives right around New York City.
Yeah, no, we'll link to that in the description below as well. And I mean, I highly recommend the two of you to anyone and everyone who could benefit from the work that you do at the knee that way. I mean, I trust you all enough to send my own family to you. And I feel like there's no higher praise than that. So I really appreciate all the work that you're doing clinically and all the amazing insights and advice that you've been able to share through multiple podcast episodes each now. The work that you're doing is absolutely incredible, and I really appreciate everything that y'all are doing. Thank you so much for your time.
You're welcome.